First Fill. My name is Katie Meyer, and I serve as the VP of Education at APHA, and I'll be the host for today's episode. In part one this month, we covered the recently updated ACC AHA guidelines for the prevention, detection, evaluation, and management of high blood pressure in older adults. Today, I'm delighted to be joined by APHA member Ryan Waldschmidt, APHA's Community Pharmacy Practice Community Chair-elect. As I said, I'm really excited to have you here today, Ryan. Welcome to the First Fill. Before we start, could you please introduce yourself to our listeners and share a bit about your practice setting and experience?
Yeah, absolutely. Thank you for having me on. Like you said, my name's Dr. Ryan Waldschmidt. I am an assistant professor of pharmacy practice at the University of Findlay here in Findlay, Ohio. I've worked at several independent community pharmacies in varying capacities. Currently, I work at Jackson Pharmacy and Wellness Center in Jackson Center, Ohio. I've also been involved as a coach with the Flip the Pharmacy Practice Initiative, which has been recently focusing on providing community pharmacists with the tools and guidance necessary to make meaningful clinical interventions to help patients achieve optimal blood pressure control. So thank you for having me on the show.
Absolutely. Thanks so much, Ryan. All right, well, let's just dive in. So let's start with the prevent risk calculator. We talked about that during episode one. Have you seen this new calculator in action yet as part of your practice? And any thoughts on how it will change the way clinicians assess cardiovascular risk and initiate treatment?
Great question. I was really excited when the Prevent Calculator was developed in 2023, as an update was certainly needed for the older, ASCVD risk calculator that was developed back in 2013. The Prevent Calculator has a much larger and more diverse sample size compared to the 2013 calculator, really comparing about 25,000 patients in the old calculator to over 6.5 million in the new calculator. It can also predict 10-year and 30-year risk for total cardiovascular disease and heart failure, in addition to ASCVD risk. The creation of the Prevent Calculator certainly changed practice dynamics quite a bit. If you were to calculate a 10-year ASCVD risk score for the same patient using both calculators, you actually get two different answers. In general, we've actually seen the Prevent Calculator tends to have a lower risk value when compared to the older 2013 risk calculator. In fact, there was actually an article in the Journal of the American Medical Association from June of 2024 that noted that the mean estimated 10-year ASCVD risk score for the old calculator was about 8% compared to about 4.3% of this new Prevent Calculator. As a side note, because of that, that study noted that about 17 million adults who were previously recommended to initiate, statin therapy they would no longer meet eligibility when using this new calculator. So when comparing the risk scores between calculators, it gives an idea of how things have changed. And it is important to note, though, that although I talk about ASCVD risk, the 2025 hypertension guidelines recommend using the total CVD or cardiovascular disease calculator for stage 1 hypertension patients when considering whether to initiate antihypertensive therapy or not. So, in the guidelines, note that a 10-year total CVD risk score of 7.5% or greater does support a recommendation for initiating antihypertensive therapy. But ultimately, it's really encouraging to see Prevent being implemented in these latest guidelines. Of course, there's no calculator that can perfectly predict the future with perfect accuracy, but I would argue the Prevent calculator is currently our best tool when predicting the 10-year cardiovascular risk.
Great, Ryan. Thanks so much for that perspective. In episode one, we also reviewed some of the most relevant changes, other changes from the guidelines, comparing 2017 to 2025. What are some examples of changes that really stood out to you and that you feel will impact your practice?
Yeah, so to me, there were four main changes that stood out to me, beyond our previous discussion regarding the Prevent calculator. The first main change had to do with the treatment of hypertension in certain special populations like pregnancy and chronic kidney disease. On the previous episodes, there was some great discussion regarding the treatment of hypertension in those patients. So I'll just encourage listeners to listen back to the previous episode if you'd like to hear a little bit more on that. But that was the first one that really stood out to me. The second one, to kind of continue our discussion on the Prevent calculator a bit further, Another difference between the new and the old calculator was actually the inclusion of race as a determinant. The Prevent calculator does not take race into account, while the old 2013 calculator had taken it into account. Similarly, in the old 2017 hypertension guidelines, there was a recommendation in section 10.1.1 specifically for Black adults with hypertension without the also had no heart failure or CKD, regarding a preference of calcium channel blockers or thiazide diuretics over some of our other options, your angiotensin receptor blockers or your angiotensin converting enzyme inhibitors. That recommendation, interestingly, was removed in this latest 2025 guideline. And the rationale seems to be based on the editor's comments was to align more closely to that prevent calculator that also does not take race into account. Kind of focus more on the CVD risk rather than sort of race-based metrics in clinical care. While it may be argued, there may still be some evidence to suggest a potentially diminished effect of ACE inhibitors and angiotensin receptor blockers in Black adults with hypertension. The main priority really should be the cardiovascular risk, calculated by the Prevent calculator when making clinical decisions. So that's really, sort of the second main thing I noticed. Another key change was the exclusion of the non-dihydropyridine or non-DHP calcium channel blockers as first-line agents. The 2017 guidelines noted that any calcium channel blocker, regardless of whether it's dihydropyridine or DHP or non-DHP, would be a reasonable first-line agent for patients with hypertension and without other comorbidities. In these latest 2025 guidelines, they actually prefer long-acting DHP calcium channel blockers like amlodipine that are preferred as a first-line agent, while your non-DHP calcium channel blockers like diltiazem and verapamil are no longer first-line agents. So that was the third main thing I noticed as well. The last key change that stood out to me had to do with resistant hypertension, which is defined as having a blood pressure above goal despite being having treatment with 3 antihypertensive medications, or a blood pressure that's at goal, but it requires 4 or more antihypertensive medications. Generally, this occurs when a patient has initiated 3 of the 4 first-line antihypertensive agents. You think of your ACE inhibitors, your angiotensin receptor blockers, your thiazide diuretics, and your DHP calcium channel blockers. And they're still above goal despite being on, sort of optimal combinations of those 4 classes. In the 2017 guidelines, according to Figure 10, after ruling out other causes and optimizing the non-pharmacologic therapies, clinicians could choose from many agents with different mechanisms of actions, things like beta blockers, alpha blockers, direct vasodilators, etc. In these latest guidelines, it's actually clear that one class stands above them all in treatment-resistant hypertension, and that's your mineralocorticoid receptor antagonists, or your MRAs, things like spironolactone. Medications in this class have the best evidence to support their use in resistant hypertension. Only then, in patients who still have uncontrolled hypertension or cannot tolerate an MRA, then we might consider some of those other therapies like beta blockers, alpha blockers, and direct vasodilators. So really, those were some of the main changes I noticed, at least from sort of my standpoint from community pharmacy and academia as well. But certainly there are others, and I encourage listeners to review the guidelines themselves to kind of review all of what they had updated.
Thanks, Ryan. Yeah, it's been quite some time since we had new hypertension guidelines for sure. So a lot's changed, and it's really important to, like you said, take a look. But also, I appreciate all your commentary on major points. Definitely valuable for listeners. All right, one last question. Any last parting words for our listeners regarding the updated guidelines for blood pressure management and major items that they should be aware of?
Yeah, I mean, while we did certainly cover quite a bit today, I would like to echo a lot of what was in the first episode regarding, the technology and not using sort of those cuffless blood pressure monitors and some other things. But ultimately, I encourage all pharmacists to, review the guidelines for themselves and make those decisions that might impact your practice. After 8 years, there's been a lot of new studies that have shaped and changed the way we think about the best ways to treat patients with hypertension. And ultimately, both with lifestyle modifications and with medications. So reviewing and referencing those guidelines will ultimately help ensure our patients receive the best evidence-based treatment.
Absolutely. Thank you so much, Ryan, for that perspective. And thanks so much for joining us today and sharing some of your experiences with these hot off the press guidelines. It's really been a great review, and we appreciate all of your time today with us. Well, let me summarize major takeaways that Ryan covered today. So, first, the PREVENT calculator is a valuable tool as it predicts both 10 and 30-year risk for cardiovascular disease, heart failure, and risk of ASCVD. Antihypertensive therapy should be initiated generally with a CVD risk score of 7.5% or higher based on the PREVENT calculator. Next, pharmacotherapy selection for Black Americans focuses less on specific drug classes now, but more on that cardiovascular risk based on the PREVENT calculator. So be sure to use that calculator when making clinical decisions around that population and make the best decisions based on all that evidence and their particular situation. The non-dihydropyridine calcium channel blockers are no longer indicated as recommended first-line agents for patients with hypertension without other comorbidities. Thank goodness, all that edema. The guidelines now prefer long-acting dihydropyridine calcium channel blockers like amlodipine. And then lastly, for patients with resistant hypertension and blood pressure above goal in spite of treatment with 3 or 4 antihypertensives, these patients should be treated with a mineral corticoid receptor antagonist like spironolactone now. That drug class is now preferred in those patients. It kind of sums up major points for today. So thanks everyone for listening to the first fill this month. If you are looking for more content in the cardiology space, we actually just released an Enduring Hot Topics webinar that's called From Statins to Strategy, Navigating the Updated Lipid Landscape. Webinar is available for free in the Learning Library for APHA members. So definitely check that out if you're looking for more content in this space. And then, as always, don't forget to visit the Learning Library at learn.pharmacist.com to earn CE credit for this month's podcast. It's there for free for members. So take care, and thanks for listening, everyone.